I can just have everyone seated if you're sticking around. So good morning. Welcome to our Pecha Kucha presentations for Track 6. My name is Rebecca Liu, and I'll be your moderator for this session. To start things off, so if you are sticking around, you're more than welcome to sit in any of the seats. But if you are heading out, can we ask if you are continuing your conversations, if we could take them out outside, because we want to get started and have our presenters come up, please. Okay, thank you. So, on behalf of the Canadian Obesity Network, we want to introduce our judges for today, Sanjeev Sokalingam, Ian Patton, and Gord Zello, and we want to thank you for providing us with your time and fair judgment. So the featured Pecha Kucha presenters for the 2017 Canadian Obesity Summit, they represent the top scoring abstracts, and prizes will be awarded to the best presentations at the summit closing ceremony on Friday, April 28th at 4:30. And along with their presentation today, you can check out their poster in the Riverview Lounge, which will be up until later today. So for our speakers, as you know, you have 20 slides, each slide shown for 20 seconds, so the slides will advance automatically. So I'll announce your name and title so you can save some of that time to present yourself and give us a bit more background, then your time will begin. Unless there's time at the end, there will be no question period, but please feel free to approach the presenters after the end of the session. So I'll begin by calling our first presenter to the podium, Gillian Balance, who will be presenting the economic impact of bariatric surgery, a retrospective cohort study.
Hi everyone, my name is Gillian Balance, and as I've just been introduced, I'm a second-year medical student at Memorial University of Newfoundland. I'm coming here today to discuss with you some of our results from the Newfoundland Labrador Bariatric Surgery Cohort Study involving the economic impact of bariatric surgery. I'm really happy you all came out today and last day. So my disclosure slide is pretty empty, kind of similar to my pockets. I don't have any financial interest to disclose today. As a student, we don't usually have many people knocking down our doors giving us extra money. As I said, I'm coming from St. John's, Newfoundland today, and on the next slide here, I just wanted to show some pictures that I took around the province at different hiking trails. And as you can see, Newfoundland, especially for anyone who hasn't been out that side of the coast, is a really beautiful area, and it has a lot of different outdoor activities that you could take part in. Unfortunately, we don't always get blessed with such sunny weather as you can see in some of those pictures, and we're usually experiencing weather like that. So, and I'm sure you can imagine that it's such a barrier to physical activity if you can't even get down to walk down your sidewalk because there's so much snow and it hasn't been plowed in a couple days. So it shouldn't come as much of a surprise that Newfoundland and Labrador has one of the highest rates of obesity in the country. Only surpassed, as you can see here, by the Northwest Territories. And 30.4% of people living in Newfoundland in 2014 were reported to be living with obesity, and which, as you can see, is significantly higher than the national average. So as we all know, obesity can have various different aspects of negative aspects on health. And I'm going to focus on some of the financial consequences to well-being today. So you can see increased healthcare risks, healthcare service use and costs, decreased quality of life, decreased workplace productivity, increased workplace absenteeism, and an increased risk of disability are all fairly common to see when you're suffering severe obesity. So bariatric surgery is the most effective treatment for long-term sustained weight loss in these severely obese patients. And we've been seeing over the past 10 years that the rates of bariatric surgery have been on the rise exponentially, with a 300% increase in order to try to sustain this long-term weight loss. So throughout the country, there are several different types of bariatric surgery that is being offered. In our Newfoundland Labrador Bariatric Surgery Clinic, we offer a sleeve gastrectomy. And we offer a laparoscopic procedure, which involves small incisions and insertion of surgical instruments rather than an open abdomen procedure. So this is less invasive. As you can see from the diagram here, so in the sleeve gastrectomy, the greater curvature and the fundus of the stomach is resected, which results in about a 75 to 80% resection of the stomach. And what's left behind is this pouch, or what we call a sleeve, hence the name sleeve gastrectomy. So in 2011, one of the general surgeons wanted to offer this as an option for treatment for severely obese patients. But it was a very new procedure at the time, and it still doesn't have a lot of data as of right now. So our study was born out of this, and my objectives is to look at the economic outcomes. So in our study, patients between the ages of 19 and 70, male or non-female patients, are offered this surgery if they have a BMI of greater than 40 or greater than 35 if there's also a severe obesity-related comorbidity like hypertension or diabetes. And they must have also tried to lose weight in the past through non-surgical procedures. So we collect our data during the follow-up visits to the clinic at 6, 12, 18, and 24 months. And we're looking at outcomes such as weight loss intervention products, mobility aids, workforce or home productivity, and employment status. So these are all within the administered surveys that they self-report on. And if we look at our patient demographics, we can see that primarily our patients are female, which is pretty consistent. Average age of 44 years of age, and on average they have at least 5 comorbidities and a BMI of 48.8 kilograms per meter squared. And these patients are usually college educated, employed full-time, and are earning a $50,000 a year household income. So looking at our first objective of purchasing weight loss products and programs and services, we can see that there's a significant decrease in the 1 and 2 years following bariatric surgery as compared to before surgery. And we also see very similar results that are coming up on the next slide when it comes to mobility and medical aids and services. At 2 and 1 year after surgery, again, we see the significant decrease in the purchasing or acquiring of these products. And then in terms of productivity, which is coming up now on the next slide, when there's required assistance from others that we're going to see in a few seconds here, this is also significantly decreased at 1 and 2 years. And this is particularly important because not only does it represent an increased productivity of the individual, but they're not taking away from the productivity of others, especially if it's a loved one in the home or someone else who is working full time. They're not expected to take time off work to help take care of their loved one. Finally, we're looking at employment status. So at 1 year post-surgery, we do see an increase in the sick or temporary disability leave, which is kind of expected because they are recovering from a fairly invasive surgery. But at 2 years, this goes down significantly. And we also see an increase in the working full or part-time. So it seems that after surgery, this is particularly improved. So in summary, we see a decrease in the purchasing of weight loss products and programs, decreased mobility and medical aids, decreased assistance from others, and a decrease in temporary and sick leave 2 years after surgery. So in conclusion, coming up on the next slide here, we see that bariatric surgery results in the decrease of indirect obesity-related costs in patients that are undergoing the sleeve gastrectomy, with the hopes that this would overall lead to a decreased healthcare costs to the healthcare system and society, but most importantly to the patients that we're serving and trying to take off that financial burden on top of their other comorbidities and health-related issues. So I want to thank you very much for coming to my talk today, and special thanks to my supervisor, Dr. Lori Twells, for spearheading this study and helping me come here today. So I hope you guys enjoy the rest of the conference.
Okay, thank you, Gillian. So up next, our second speaker is Alison Holgersson, who will be presenting a relationship of weight loss expectations to bariatric surgery outcome.
We'll just start. You never know with the timing of this. Should I press forward? Okay. Well, thank you all for being here today and for the committee for inviting me to speak. I'd also like to acknowledge my co-authors listed here. And this research really came out of a clinical interest about how to be best prepared to have really difficult conversations with our patients about weight loss expectations. So as I was introduced, my name is Alison Holgersson. I'm a clinical psychology fellow at Mayo Clinic in the Rochester, Minnesota location. So not too different from Canada, although we're getting a little bit warmer now. And our clinic is a tertiary clinic, so we tend to see more complex patients, which will come up in our patient population in just a bit. So I don't need to reiterate to all of you that obesity rates have risen drastically over the last decades, causing great physical, psychological, and economic costs, as we just saw, to individuals and society at large. Unfortunately, this isn't exclusive to the US or Canada, and not to humans. I currently have a cat who's on the Catkins diet, as prescribed by his veterinarian. So it's in my household too. Unfortunately, as this comic suggests, long walks simply aren't enough. And so we can think about the pyramid of obesity intervention, the bottom being lifestyle, followed by medication, endoscopic procedures, and finally bariatric surgery procedures. As we rise in the pyramid, we see greater percent weight loss, but also greater risk. So there's a number of considerations. The evolution of bariatric procedures has been large. In the US in the 1990s, they were completing about 16,000 surgeries. This rose tenfold by 2011 and has increased since. We've also seen a great proliferation of different types of interventions, yet only about 10% of individuals who are eligible undergo bariatric procedures. I was hoping to talk today about the venti, as so to speak, of bariatric procedures, that being the biliopancreatic diversion with duodenal switch, which is typically reserved for patients with a BMI over 50, and you get the restriction of the sleeve gastrectomy and 3/4 of the small intestines bypass, so really the largest majority of malabsorption. So after surgery, individuals must heal, of course, but then recommended to follow certain lifestyle guidelines, which are really important to avoid complications, get the most weight loss in that first 12 to 18 months, and prevent regain. And of course, we need to do this by helping our patients maintain motivation. One way that motivation can be infected, unfortunately, is by expectations. So expectations for weight loss, we know that they are typically unrealistic, as well as other things, so reduction in comorbidities, self-esteem, body image. And if you're frankly unimpressed, as you see here, by your expectations or weight loss, it might actually impede your motivation to adhere to post-surgical guidelines. So a really big impact. A seminal study by Foster and colleagues about 20 years ago now showed that people who were engaging in lifestyle intervention would be disappointed with 17% weight loss. We know that we can achieve about 5 to 10% weight loss, so unfortunately, we can't even get people disappointed. We're really fighting an uphill battle here, and this is seen in bariatric procedures as well. So in our practice, all individuals first see an endocrinologist and then concurrently see us for an evaluation, as well as a 12-week behavioral weight management program with other disciplines, and then following that, seeing the surgeon. So there are many points to intervene here to maybe identify those who might be most at risk for different motivations and how we can impact those. Patients for this study were 97 individuals who completed the goals and relative weights questionnaire, asking them to identify how much weight in pounds they would need to achieve to achieve dream, happy, acceptable, and disappointed weight statuses. This is about 94% Caucasian, 78% female, and an average BMI of 46. And here we see those expectations. These were converted into percentage of weight loss. You see those who undergoing the switch had the highest expectations, followed by the sleeve gastrectomy and finally the Roux-en-Y. And it's important to note that about 0.6% overall of procedures are switches. In this sample is about 15% of the population, and that's pretty typical for our clinical sample, about 10 to 15%. We then did linear regressions controlling for pre-surgery BMI and saw that those who had the highest dream weight loss desired actually had greater weight loss at 1 and 2 years. And this was about 12% between low and high expectations at 1 year and 13% total weight loss at 2 years. So we're talking about significant numbers here. So this is the first study to our knowledge to understand the expectations of those undergoing the biliopancreatic diversion with duodenal switch. And also, we saw that even controlling for pre-surgery weight, those who had the highest expectations actually might be facilitated by that and had better outcomes. So how can we harness this clinically? Well, one way is to kind of take that 30,000-foot view and really go back to basics of goal setting, really helping our individuals, our patients understand that there can be many different types of goals that they can set, and they can come in many shapes and sizes, so to speak. So having many different targets. One way to do that is by looking at percent total weight loss instead of percent excess weight loss. And so this might be easier just for everyone, for us, and for our patients to calculate and keep track of, to understand, but it also doesn't require the calculation of an ideal BMI. And so we can kind of step away from that. And speaking of BMI, helping individuals and consulting with them to understand that although they might lose a significant amount of weight, they might still be in an overweight BMI category and that that's okay. We want them to look at other markers of success. So I'm more active with my friends and family, I have more energy, I'm feeling better, my diabetes is better under control, really looking at the holistic picture rather than just the weight itself. And so when we think about that pyramid of interventions, we go back to that, it's likely that individuals whose expectations for weight loss match the procedure type or the intervention type are likely to have the most motivation. But of course we need to research that. So we also want to understand, are there certain factors like self-efficacy or social support that actually facilitate those outcomes for individuals who have high expectations? And so when I think about this clinically, I think one way is to make sure that we're educating our patients without bursting their bubble, so to speak. We want to bring down their unrealistic expectations, but also empower them to take ownership of what they can achieve. And so one way to do this is by going back to the basic goal-setting literature, which really encourages us to help people find that sweet spot, to step out of their comfort zone so that they can be achieving something that doesn't feel too easy, while also encouraging them to be just a little bit bold. And if you're a little bit bolder with your expectations, that might actually facilitate outcomes and give you what you desire. Thank you.
Thank you, Alison. So next up, we have our Aurélie Béot, who will be presenting long-term impacts of adding supervised exercise training to interdisciplinary lifestyle management in subjects awaiting bariatric surgery.
I'm very happy to be here to share with you the 1-year post-bariatric surgery result of a pre-surgery exercise training that was part of my postdoctoral training, especially in this very special format that is new for me, but very challenging and exciting. As you know, bariatric surgery offers large impact to individuals with severe obesity, massive weight loss, health and quality of life improvements. For this reason, the number of bariatric surgery has remarkably increased during this last decade in North America. Just large impact. Physical activity is recommended by experts before and after bariatric surgery. However, we don't have any specific recommendation for this population. That's why we need to work on that, and we use the famous 150 minutes of moderate to vigorous physical activity. Before bariatric surgery, the vast majority of patients are inactive, and after bariatric surgery, despite the massive weight loss, the vast majority of patients remain inactive. Recent studies show that only 3% of individuals with before bariatric surgery have a markedly increase in physical activity after bariatric surgery. The pre-surgery period could be an ideal starting point for physical activity intervention because the motivation to practice physical activity increased significantly close to the date of surgery. And people with a higher level of physical activity before surgery have a higher level of physical activity after surgery. Recently, we show that pre-surgery exercise training have significantly improved, pre-surgery exercise training can significantly improve physical fitness, social interaction, and also embarrassment during physical activity. But now we need to know if these benefits are maintained after bariatric surgery. That's the aim of our study was to compare baseline to 1-year post-bariatric surgery change after pre-surgery exercise training on physical activity, physical fitness, quality of life, and physical activity barriers. And the mean age of our sample was 43 years old, with a majority of women, majority of gastric bypass. We randomized 30 subjects candidates for bariatric surgery in the Centre Hospitalier Universitaire de Sherbrooke. They were randomized in the exercise group or in the control group. Data were collected before surgery at 3 time points, before and after 12 weeks of exercise training, and 2 weeks before bariatric surgery, and also at 4 time points after bariatric surgery at 3, 6, 9, and 12 months. And as you can see, the exercise training was performed only before surgery. Body composition, physical activity barriers, quality of life, submaximal physical fitness, maximal aerobic capacity were collected at these different time points, and accelerometer data were obtained one year after bariatric surgery. The control group and the exercise group received usual care, that was lifestyle and individual counseling before and after bariatric surgery, and the exercise group received in addition 3 weekly exercise sessions of endurance and strength training with a monthly aquatic session. Our results show that 3/4 of the exercise group reached physical activity recommendation 1 year after bariatric surgery, and only 30% in the control group. Participants in the exercise group had a 3,000 steps, additional 3,000 steps per day compared to the control group, so thus our exercise group is more active 1 year after bariatric surgery. The exercise group had a better improvement in physical fitness 1 year after bariatric surgery. More exactly, that is submaximal physical fitness, that is the 6-minute walking test distance, that have a better improvement, and the half squat test time. For maximal aerobic capacity, there is no significant difference between the 2 groups. However, these data are in accordance with the results of our accelerometer data that show that there is no significant difference between groups for vigorous physical activity, reducing the opportunity to increase maximal aerobic capacity. The exercise group had a better weight loss 1 year after bariatric surgery. The mean difference was 3 kilograms per meter square. That is not a lot, but in my opinion, the major interest of physical activity after bariatric surgery is weight loss maintenance. In contrast with our short-term results, we didn't find any difference between groups for quality of life and physical activity barriers. However, as you know, bariatric surgery has a massive impact on quality of life that probably have masked the impact of physical activity 1 year after bariatric surgery. This study is the first randomized control study to investigate the long-term effect of a pre-surgery exercise training in subjects awaiting bariatric surgery. To our knowledge, there is only one recent study which reported that the benefit in terms of physical activity level after a pre-surgery bariatric surgery physical activity counseling are maintained 6 months following bariatric surgery. There is several limitations in our study. We have a small sample size. We don't have baseline accelerometer data and no nutritional information about the change before and after surgery. So, to conclude, as you can see, even Superman is not immune to become inactive, so it's important to provide support to individuals to candidate for bariatric surgery, and supervise this training before surgery seems to be promising to improve physical activity level and physical fitness 1 year after bariatric surgery. But now we need to do study with larger cohort and to test like some different modality of intervention or modality of delivery. Thank you for your attention.
Thank you, Aurélie. So we have a quick change. Our final speaker today will be Karen Kantorovich, who will be presenting psychosocial predictors of cognition in bariatric surgery candidates.
ça là.
Good morning, everyone. So my name is Kantorovich. I am the research coordinator at the bariatric surgery program over at Toronto Western Hospital. So there was a quick change. Unfortunately, the lead on this study was not able to make it in today, so I'll be presenting the results on his behalf. So our study was looking at psychosocial predictors of cognition in bariatric surgery candidates. So bariatric surgery patients comprise a severely obese population. The prevalence of psychiatric disorders among these patients is incredibly high. Around 60% of these patients will be diagnosed with at least one of these disorders listed in the chart at some point in their life. And of these disorders, depression, anxiety, and binge eating disorder are the most common. So in addition to the high rates of psychiatric conditions that I just described, neurocognitive deficits such as problems with memory, attention, and executive functioning, like planning and organization, have been linked both to obesity as well as psychiatric illness. So I'd like for us all to imagine a hypothetical patient. We can call her Mary. So Mary, she has a BMI of 42, diagnosis of major depressive disorder, anxiety disorder, and diabetes. She complains of difficulties working and poor quality of life due to her difficulties with concentration and memory. Many of the clinicians in this room, I'm sure, who have worked with patients with severe obesity can relate and have had sort of these types of patients in their practice. So neurocognitive testing has verified that individuals presenting with severe obesity like Mary endure significant cognitive complaints. In fact, in a recently published systematic review conducted by our team, we found that there is improvement in most cognitive domains following bariatric surgery. However, most of these improve in the short term. So here we have an illustration of just how common cognitive issues are across psychiatric disorders, including mood disorders and depression. So on the left is a list of psychiatric conditions, and then the top panel describes the affected cognitive domains. In patients who are not obese, these impairments have been found to predict much greater disability. So this is just a visual representation. It was results taken from a 2015 study describing the impact of cognitive deficits that are associated with depression. What it's essentially showing us is that in patients with major depressive disorder, the cognitive impairment impacts work capacity more than actual depression symptoms themselves. So the underlying premise, considering the current literature, is first off that mental health issues are common among severe obesity. There are cognitive issues related to mental health issues, and so what needs to be explored now is the relationship between neurocognitive impairment and psychosocial factors. So in order to begin to explore these relationships, the research aim for our study was to identify the relationship between psychosocial variables and perceived cognitive deficits in bariatric surgery candidates. By perceived cognitive deficits, we were interested specifically in seeing patient reports of their own memory, attention, as well as cognitive functioning. So we predicted that psychosocial variables, specifically depression, anxiety, and body mass index, BMI, would be associated with self-reported cognitive impairment, and that greater cognitive deficits would be associated with increased employment impairment and decreased quality of life. So with quality of life, we were looking at physical and mental components. And the study was conducted, it was a cross-sectional investigation at the University Health Network, Toronto Western Hospital. We recruited 302 preoperative patients from the BariPsych database at the Toronto Western Hospital Bariatric Surgery Program, and all patients were above the age of 18 and completed all assessments for the surgery. So the data included in the study analysis, we collected demographics on all of the patients along with various psychosocial measures. We used the LEAPS, it's the Lamb Employment Absence and Productivity Scale, to assess employment impairment. The PHQ-9 was used to look at depression, anxiety, we looked at GAD-7 scores, and quality of life, we used SF-36, both the mental and physical components. So this is the PDQ-5. It was our cognitive measure. It was originally developed for patients with multiple sclerosis. It's a 5-item scale measuring attention, retrospective and prospective memory, and executive functioning, so generally cognitive measures. Although it has low correlation with neuropsychological testing, instead it measures factors related to perceived cognitive impairment on behalf of the patient. So just a quick snapshot of our sample's demographics. Like many of the other presenters mentioned today, it echoes an unusual norm of a Caucasian female, mostly employed. And the average number of medical comorbidities in our patient sample was approaching to 4. So what were our findings? Well, depression, anxiety, and overall mental quality of life scores were significant predictors of cognitive deficits in bariatric surgery candidates. However, neither BMI nor overall physical quality of life were associated with cognitive symptoms. So having a look at our LEAP scores, in our follow-up analysis, we took out the psychosocial variables to see the direct impact of these scores on perceived cognitive deficit. So this showed that impairment was significantly associated with the presence of perceived cognitive deficits, independent of psychosocial measures and BMI. This was demonstrating that it's not just mental deficits that are indirectly influencing productivity, but also it means that patients with mood disorders, employment impairment, and poor mental quality of life all feel they have a harder time with cognitive functioning. So making these variables key predictors when evaluating candidates for bariatric surgery. But also cognitive deficits in these patients are related to work impairment. So while we did use valid measures and examined functional impact of perceived cognitive problems, some of the drawbacks in our study was our design, the lack of an objective measure of cognitive impairment, and our study sample size was limited to bariatric surgery candidates, who are only a subset of patients with obesity. So looking at moving forward, we hope to longitudinally follow up our patient cohort and to implement formal neuropsych testing to see how it might compare to the perceived cognition that we measured. It would also be good for future work to examine these variables across other obesity treatment settings outside of the severely obese population. So I'd like to take the last 20 minutes just to thank our team at the Toronto Western Hospital. This is an incredibly multidisciplinary group without whom data collection for our studies just wouldn't be possible. And an equally bigger thank you to our patients in our program who agreed to graciously let us use their data for our research. So thank you.
So thank you, everyone. Let's give our presenters another round of applause. It's not easy doing this type of presentation. So best overall presentations will be announced at the closing ceremonies today at 4:30. So please help yourself to lunch in, I guess, Van Horn and in Riverview. And we'll see you later. Thank you so much for coming.